Good evening, guys. Happy Vijay Dashmi to all of you. And today is a festival day, but still, I thought to continue with the live session so that your schedule is not interrupted in between because of anything, right? But anyways, today, guys. So as you can see, we are to the 9th week, blood and GIT. These are the two topics we are going to cover today. And week by week, you can see we are already reaching towards the fag end of pharma. And I hope this is helping you guys. And today, good evening, Abhinandan Maiti and Vishwas D. Arshita Singh. A very good evening to all of you. So, moving ahead, guys. In today's, I hope you guys can hear me. If the audio and video is clear, I hope it is clear. So, just let me know. Happy Vijay Dashmi to all of you. So, is it clear, guys? The video, audio, everything is clear? All right. So, let's start with today's session, guys. Okay, it's getting stuck. Thank you very much. It's getting stuck. Okay, let me see. Okay, there is some problem with internet, I think. Okay, just guys, give me 5 minutes. Give me 5 minutes. I think I have to restart. I think I have to restart my Wi-Fi. Let me see. Let me do that. So guys, can you guys hear me now? Is it okay now? Okay. All right. So I'm sorry for the delay, guys. There was some problem with. That's good. Yeah, there's some problem with my Wi-Fi, I think. Anyways, so guys, let us not waste any time. Let us begin with today's session. And excellent. I'm sorry for the delay. All right, guys. So today, blood and GIT, we're gonna rock these two topics today. And let's begin, guys, today's session. All right, straight away to the first question, guys. A patient of chronic renal failure has been recently diagnosed with atrial fibrillation and is to be given anticoagulant prophylaxis. The preferred one among the following will be, right? Apixaban, dabigatran, fondaparinux, LMWH. Nikhil Singh, thank you very much. All right, guys. Let's begin. Patient of chronic renal failure has been recently diagnosed with atrial fibrillation and is to be given anticoagulant prophylaxis, the preferred one among the following is. All right, so whatever you think is the right answer, guys, let me know. So I've told you in every session, I'll try to ask questions which are new ones, which have never ever been asked. This MCQ has never been asked. All MCQs that we'll find today are the new ones, right? They've never been asked. All right, guys, come on. Give me one answer, guys. Come on, at least one answer, at least one option. Whatever you think is the right answer. Apixaban, dabigatran, fondaparinux, or LMWH. Is it A, is it B, is it C, or is it D? UFH should be used, but say for anticoagulant prophylaxis, I have to give long term, right? And long term UFH is not possible. All right, guys. So again, something new we will learn. Your answer is apixaban. Some of you have given right answer. Your answer here is apixaban. Now remember, DOAC. I should avoid in renal failure. I should avoid DOAC in renal failure. But in renal failure, if they ask you which is the DOAC of choice, then your answer would be apixaban. Your answer would be apixaban, right? C and D are never used. So see, in your exams, you'll have such kind of MCQs where you can rule out two options. You can easily rule out two options. Remaining two options, you have to go for the answer, right? You have to go for the answer. So here, answer. So apixaban. So if they ask you, so remember, apixaban, I'm not saying it is a preferred anticoagulant in renal failure. I should avoid DOAC altogether. But if I have to use a DOAC, the DOAC of choice would be apixaban. So this is one new point that we need to learn here, right, guys? Now moving on to the second MCQ. A patient of rheumatic heart disease has mitral valve stenosis with an area of 1.2 centimeter square. That is the area of mitral valve. Which of the following anticoagulant should be given prophylactically in the patient? Dabigatran, apixaban, warfarin, LMWH. Again, this is a new MCQ which I've made for you guys specifically, right? Which is clinically relevant, and similar MCQs have been asked in your exams, but not this one exactly, right? So our aim here is to solve some new MCQs. So guys, what do you think is the answer here? Dabigatran, apixaban, warfarin, and LMWH. Is it again getting stuck, guys? Right. So what is the answer? So excellent, guys. Most of you given the right answer. Warfarin is the right answer. So this is something we have read about this, that whenever there is mechanical valve and whenever there is native valve, whenever there is mechanical valve M, I'll reverse M, I'll get W, warfarin. So in mechanical valve, I use warfarin. Native valve, I use DOAC. This much we know, right? I use DOAC if there is severe mitral stenosis, that is the area less than 1.5 centimeter square. Severe mitral stenosis, area less than 1.5 centimeter square. Even if it is native valve, still I'll go for warfarin, right? So mitral stenosis, M for mitral stenosis, the reverse is W, warfarin. So excellent, guys. All of you have given this right answer. That means you guys are prepared well, right? Now moving on to the next question. Seraparantag is a wide spectrum antidote against all of the following drugs except. Seraparantag is a wide spectrum antidote against all of the following drugs except. Look at the options: heparin, fondaparinux, DOAC, and warfarin. So these are the four options we have: heparin, fondaparinux, DOAC, and warfarin. All right, guys. So let me know what is the answer here. Antidote against all of the following drugs except. Look at the Seraparantag is a wide spectrum antidote against all of the following except. Right. So what is the answer? Alright, so comment whatever you know, whatever is the possible answer, whatever you think is the answer, you can comment. Anyway, so if you have gone for answer B, if you have gone for option B as the answer, then let me mind you, many of you have gone for option B. Option B is wrong. Option B is wrong, though this was the answer in one of your MCQs, which is asked in INICET. That MCQ was wrong. That MCQ was wrong. Now, why that MCQ was wrong? Let me tell you. See, guys, here the answer is warfarin, and why the answer is warfarin? See, look at this drug, Seraparantag. Seraparantag has multiple binding sites: blue color, violet color, green color, yellow color, and all of these sites you can see here. These are the binding sites for apixaban, dabigatran, edoxaban, fondaparinux, rivaroxaban, UFH or LMWH. It means what? What do I get to learn here? That one point, Seraparantag, it's a wide spectrum. Seraparantag, it's a wide spectrum antidote against all drugs. It is an antidote against all drugs with one exception, and that exception is warfarin. There is only one exception. That exception is warfarin. That is what I need to learn. That is what I need to learn. So you can see here, this MCQ was wrong. And I'll not go into the details of why the examiner made the MCQ wrong, because the examiner took the information. Because the examiner took the information from Goodman-Gilman, where it was written heparin group of drugs, right? So if you look at Goodman-Gilman, they have written Seraparantag is active against heparin group of drugs, and the examiner misread it. Heparin group of drug does not mean only UFH and LMWH. Even fondaparinux belongs to the heparin group of drugs. I've taught you this, right? Anyways, so that is the reason why. That's the reason why I have made this MCQ, so that I can teach you what is right. Based upon MCQ, I need not make wrong assumptions, or I need to learn wrong things, right? Alright, so I made another new MCQ, guys. It's an image-based MCQ. A patient was started on warfarin and developed side effect given in the image. All of the following can be used in management except. A patient was started on warfarin and he developed the side effect given in the image. All of the following can be given in management except, right? So protein C concentrate, FFP fresh frozen plasma, vitamin K, or 4-factor PTC or prothrombin complex, right? So this MCQ is a fairly clinical MCQ. It's an expected MCQ, and comment whatever you think is the right answer. You might get the answer wrong. It is okay. It's fine. We're allowed to do that, right? Here I'm allowed to go wrong so that I go right in the exam. All right. All right. All of the following can be used in the management except. So all of you have gone for answer as option A. Guys, tell me something. Have I asked you what is the cause? What is this? First of all, it is warfarin induced skin necrosis. It is warfarin induced skin necrosis. And what is the cause of warfarin induced skin necrosis? It is a rapid decline in protein C. Warfarin induced skin necrosis, it is due to rapid decline in protein C. What I'm asking, all of the following can be used in management except. So why are you giving option A? Can I use protein C concentrate? Yes, I can use, guys. I can use protein C concentrate, right? Can I use FFP? Yes. FFP has protein C. I can use it. Can I use vitamin K? Can I use? Yes, I can use vitamin K because it would reverse the effect of warfarin. Can I use 4-factor PTC for this particular purpose? No, because 4-factor PTC does not have protein C. So the answer is D. Because see, 4-factor PTC will be used to reverse bleeding that is caused by warfarin. Here, this is not bleeding, this is thrombosis caused by warfarin, and that is due to decline in protein C and not factor 2, 7, 9, 10. So why am I supposed to give factor 2, 7, 9, 10? I hope this is clear, right? So here, D is the right answer, guys. I hope you have learned something new today. That how can I treat warfarin induced skin necrosis? If the patient develops warfarin induced skin necrosis, how can it be treated? Right. So obviously this is a difficult one, and as I said, I'll be asking difficult MCQs in these sessions, but I'll not ask anything out of this world. All of you know about skin necrosis. All of you know vitamin K. All of you know FFP. All of you know PTC. The only thing I've done is I've made this clear in your mind about skin necrosis. All right, let us move on to the next MCQ, guys. A patient on anticoagulation therapy developed the side effect given in the picture. Which of the following might be the reason for this same, right? Paradoxical thrombosis, cholesterol embolization, drug-induced pigmentation, vasoconstriction. All right. Innocent answers. Yes, innocent answers. A patient on anticoagulation therapy developed the side effect given in the picture. Which of the following might be the reason for this same? Which of the following might be the reason for this same? So guys, what is the answer? Take your time. Let me know what is the answer. Very good. Purple toe syndrome. Soumya Sri Ketra Gowda. Dr. Gowda has given the answer right. This MCQ has been asked. But see, I've changed the MCQ. Because I told you these MCQs are not about PYQs or previous year's questions, right? Some of you guys have given the answer right. If you would have gone through my lectures in the revision videos, I've covered this. Very good, guys. It is due to cholesterol embolization. Is not due to paradoxical thrombosis. Because of paradoxical thrombosis, what happens is this one. Skin necrosis is due to paradoxical thrombosis. It is not drug-induced pigmentation. Drug-induced pigmentation is a pigmentation that is seen with amiodarone causing blue-gray pigmentation, right? Here, it is due to cholesterol embolization. What warfarin does, it can scrap cholesterol from the blood vessels which are deposited on the walls of blood vessels, and those cholesterol can embolize your blood vessels, giving a purple appearance not only of the toe but also of the feet, though the classical term used is called as purple toe syndrome. Though it is called as purple toe syndrome, but remember the whole feet can be purple. So anyways, you learned something new today. What is the cause of purple toe syndrome? It is cholesterol embolization. Let us move on to the next drug. Aspirin was given to a patient for prophylaxis of MI. The mechanism of action for aspirin for same is by inhibiting thromboxane A2, prostaglandin, cyclooxygenase 1, cyclooxygenase 2. So see, anti-aggregant, the MCQs are very easy. They're easy ones. Mostly the MCQs are on mechanism of action. So there is a reason why I did not want to unnecessarily give you difficult MCQs with respect to aspirin. So aspirin, I just wanted to give you a simple MCQ. Aspirin was given to a patient for prophylaxis of MI. The mechanism of action for aspirin for same is by inhibiting. All right. Now I can see what some of you guys are doing. I can see what some of you guys are doing. Some of you guys are going for thromboxane A2. And I'm sorry to say, thromboxane A2, it is an innocent answer, but it is not the right answer. The reason being, here you have lost the battle to English language. Inhibiting. Aspirin does not inhibit thromboxane A2. Aspirin inhibits cyclooxygenase 1, and that decreases that decreases synthesis of thromboxane A2. That decreases. So see here the answer is not in pharma per se. The answer here is in the English language. That is where you have lost the battle. It blocks. So for example, if I change this MCQ, right? Aspirin was given to the patient. Aspirin, right? So it acts by decreasing synthesis of what? Then your answer would have been thromboxane A2. Then your answer would have been thromboxane A2. So mind it, read the MCQs carefully. A lot of times they are misleading. So thromboxane A2 was the honey trap here. And some of you guys, you got trapped, right? Moving on to the next MCQ. Which of the following is not an off-label indication of tenecteplase? Which of the following is not an off-label indication of tenecteplase? Ischemic stroke, pulmonary embolism, NSTMI, STEMI. It's not a difficult MCQ, but the way I have construed it, the way I have made the MCQ, it might seem difficult. It might seem confusing, but it is not difficult. Let me tell you, it's not a difficult one. But let me warn you, I made it specifically, I've arranged the MCQ in such a way that it would seem difficult. Which of the following is not an off-label indication of tenecteplase? All right, that is what I thought. That is what I thought. Most of you guys will fall for NSTMI, and that's the wrong answer. That's the wrong answer. Let me tell you why it is the wrong answer. See, NSTMI is not a use altogether, right? STMI, it is a labeled use. Ischemic stroke and pulmonary embolism, these are off-label use. These are off-label use. Did you get my point? So I told you earlier, this MCQ is not difficult, but the way I have made this MCQ, it becomes difficult because I made it in such a way. So remember, tenecteplase is not approved by FDA for stroke or pulmonary embolism, right? So the only labeled use is STMI. So anyways, if you go wrong, it is fine. If you're not able to solve MCQs right in these sessions, please don't take it into your heart. It's okay. It's fine to go wrong. And remember, not all the MCQs would be such difficult in your exams. Here, what we are trying to do is we're trying to train your brain to solve the most difficult possible MCQs, right? So anyways, yeah, I'm good English language teacher, Abhinandan Maiti. So anyway, so I just, because see, they change the English language, and because of which they make it difficult for you guys. Anyways, moving on to the next question, guys. A patient of chronic renal failure was prescribed darbepoetin, right? Darbepoetin. Which of the following will not increase in the patient? So this is an MCQ that I have combined pathology with pharmacology, right? So darbepoetin is an erythropoietin analog, and I use it for anemia of CRF or chronic renal failure. Which of the following will not increase in the patient? Hematocrit, hemoglobin, reticulocyte count, serum ferritin. Serum ferritin, right? So what is the answer here? Now this is not a difficult one. This is not a difficult one. This is an easy one. This is an easy one. This is an easy one. And I'm serious. I'm not joking. There is no honey trap in this case. It's only honey. It's only honey. There is no trap. Only honey. Anyways, guys, so most of you given the right answer, serum ferritin. Now, serum ferritin will not increase, rather, serum ferritin is decreased. The reason being, see, whenever I use darbepoetin, it will increase the number of RBCs, right? And because of that, the blood becomes more viscous. It becomes more viscous. Hematocrit increases, hemoglobin increases, reticulocyte count also increases. But iron decreases as well as serum ferritin decreases. Iron decreases as well as serum ferritin decreases. And why iron decreases or ferritin decreases? Because when you are making more RBCs, your iron store would get depleted and serum ferritin will decrease. So all of you have given the right answer here. Excellent, guys. I'm proud of all of you. Pegfilgrastim is used in patients on chemotherapy who develop neutropenia, who develop infection and fever, primary prophylaxis of neutropenia, secondary prophylaxis of neutropenia. Right, so what is the answer here? Pegfilgrastim is used in patients on chemotherapy who develop neutropenia, who develop infection and fever, primary prophylaxis of neutropenia, secondary prophylaxis of neutropenia. So all of you know about pegfilgrastim. It has been asked multiple times. The reason I made this MCQ is so that if you guys don't know, I can make you realize what is the role of pegfilgrastim with respect to chemotherapy. Right? So whatever you think is the right answer, you can go for one answer. You can just choose one answer, go for that one answer, right? Is it A, B, C or D? All right, so most of you guys are going for either C or D. So if you'll mark either C or D, then you are in the safe zone. Here, C is a better answer. C more than D. Primary, so I can use it for both primary and secondary prophylaxis. But it is most important use is in primary prophylaxis. The reason being, I'll not wait for the patient to develop neutropenia. That is secondary prophylaxis. If it develops once, then I give it second time so that to prevent neutropenia. So I rather use it from the first hand itself, primary prophylaxis of neutropenia before chemotherapy. Now, if a patient develops neutropenia or if the patient already develops infection and fever, then obviously I'm going to use antibiotics. Dr. Turtle, is this session useful for INICET? See, this session is useful for any exam. And if you know that why I'm doing this weekly pharma is altogether a different thing, which I'm doing. So I can use antibiotics. They ask you which antibiotics should not be used. I should not use antibiotics like linezolid. This is one MCQ they had asked. Now, why should I not use linezolid? The reason being, linezolid can itself cause bone marrow suppression. Yes, it is, Dr. Turtle, it is useful for INICET, NEETPG, FMGE, whatever exams you're giving, it is important, right? All right, that's all with the blood part. Now let us come to GIT. A patient on sucralfate was supposed to be started on antacids. Antacids should be given after how many minutes of giving sucralfate? A patient on sucralfate was supposed to be started on antacids. Antacids should be given after how many minutes of giving sucralfate? 30 minutes, 60 minutes, 90 minutes, 120 minutes. PSM aspect, I don't know. PSM aspect. See, application of PSM, you can say. All right, how many minutes? So again, I made a new MCQ that asked you about excellent, guys. Excellent. Most of you guys have given the answer right here. So I've discussed this in my lectures, right? Now, some of you who Aksana, Anushri Bansal remembers Aksana. Excellent. So see, Aksana will give you the answer here. Now, someone has commented 120, that is wrong. 120 it is the MCQ that asked about phenytoin being taken with sucralfate. Phenytoin is supposed to be taken 120 minutes before sucralfate. Antacids, it is to be taken 30 minutes, right? So for those who have not attended my lecture, just let me tell you quickly what is Aksana. So as for sucralfate, from here we can remember when to give antacids. So remember, antacids we are supposed to give after sucralfate. Kana is food. Kana is food. We need to give before sucralfate. Any other drug we need to give before sucralfate. Na means no. These are not to be given, right? How much time? 30 minutes after sucralfate antacid, 1 hour before sucralfate khana or food, 2 hour before sucralfate other drugs. This was asked in INICET. How many minutes before sucralfate should I take phenytoin? Your answer was 120 minutes, right? So I've explained this in the revision video so that you can easily remember with the help of this mnemonic, Aksana. So Aksana, all of you, do you guys know what is Aksana? What is the meaning of this word Aksana? Do one of you know, guys? Aksana का मतलब क्या है पता है आप लोग? अक्साना कभी सुना आप लोगों ने? अक्साना है क्या? किसको पता है अक्साना क्या है? All right, let's move on to the next question. Which of the following statement Mohan Raj KN is asking, sir, can you explain why sucralfate is supposed to be given like this? See, Mohan Raj, I've covered this in my lecture. Sucralfate, just imagine what is sucralfate. Suppose this is your ulcer. This is your ulcer. And sucralfate, whenever you take the syrup of sucralfate, antacid polymerizes it to get converted into a fevicol or sticky substance. So I need hydrochloric acid to polymerize it. So if there is antacid, it would not work. Now, this polymerized sucralfate is like fevicol, sticky substance, and that is the reason why other drugs will stick to it. Third, it needs to be laid down on the ulcer. So if there is food in the stomach, how is it going to lay down all the ulcer, right? These are the reasons. See, Oksana is a Russian name. Ladki ka naam hai, right? It's a name, Russian name. Which of the following statements is false regarding vonoprazan? Which of the following statements is false regarding vonoprazan? Right, so potassium competitive acid blocker can block only food-induced acid secretion, reversible blocker, use in H. pylori. Use in H. pylori, right? So potassium competitive acid blocker can block only food-induced acid secretion, reversible blocker, used in H. pylori. So see, vonoprazan, I think sooner or later they will ask you about vonoprazan. See guys, recently I have done a session on new drugs. There is a session I've done on new drugs, and that session is on Marrow YouTube channel. It's on Marrow. Go to Marrow YouTube channel. You'll find a session on new drugs 2023. It is a session of 30 minutes. Where I've covered all the new drugs. I've even covered vonoprazan. So go through that session, you'll get at least one MCQ in the next INICET exam, right? Very good, guys, very good. B is the right answer. So those of you guys who have attended that session, you might know the answer why it is this. The reason being, see, vonoprazan differs from PPI. Vonoprazan does not need activation by acid, right? PPIs, proton pump inhibitors, they need to be activated by acid in the parietal cells. So whenever you take food, that releases acid in the parietal cell and that activates PPI, right? Vonoprazan does not need any activation, and that is the reason why it can block not only food-induced but also basal acid secretion. So vonoprazan is a much more faster acting drug. It is a potassium competitive acid blocker, that is true. It is a reversible blocker, that is true. PPIs are irreversible blockers. It is used in H. pylori, it is true. It is used along with amoxicillin and clarithromycin, right? Amoxicillin and clarithromycin. Excellent, guys. So I've covered this. Which of the following drug is not a first line in treatment of constipation? Which of the following drug is not a first line in treatment of constipation? Bisacodyl, PEG is polyethylene glycol, and milk of magnesia lactulose. So, the following drug is not a first line in treatment of constipation. It's again getting stuck, guys, I think. Anyways. So, which of the following drug is not a first line in treatment of constipation? Bisacodyl, polyethylene glycol, milk of magnesia lactulose. Which is not a first line drug in constipation? What do you guys think? I've even covered this. I've told you this as well. So the answer is, some of you have given the answer right. Lactulose, I've told you lactulose is a second line drug. I've told you this, lactulose is a second line drug. The reason being, why lactulose is second line, the reason being it is costly. It is costly, so I should not go for lactulose. Before trying lactulose, I should go for either a drug like bisacodyl or polyethylene glycol or milk of magnesia. Even milk of magnesia can be used. It is also a good drug. It is effective drug, right? So anyways, so this is one. So see, GIT, there are not a lot of MCQs. Excellent. Which of the following is least effective drug in constipation? Bisacodyl, lactulose, polyethylene glycol, docusate sodium. So go for a guess. What do you think would be the answer? Which of the following is least effective drug in constipation? Bisacodyl, lactulose, polyethylene glycol, and docusate sodium. Which is the least effective drug in constipation? Just go for whatever you think is the right answer. JK Mondal, Shubho Mahastami, Tomake bhi, ami tomake bhalo pasi. All right. So bisacodyl, lactulose, polyethylene glycol, docusate sodium. Which is least effective drug? Excellent, guys. Most of you have given the answer right. Option is D. See, docusate sodium is not the most effective drug out there for constipation. The reason being, docusate sodium, it is a surfactant which will decrease the surface tension and it produces cracks in the stool. So water can enter into those stool and it will make the stool soft. So these are stool softening agents, docusate sodium. These are not very good drugs. They are rarely used. Other drugs are good drugs. They are more commonly used. Anyways, very good, guys. Metoclopramide at high doses. Metoclopramide at high doses blocks D2 and 5-HT3, blocks D2, 5-HT3 and 5-HT4, blocks D2 and 5-HT3, stimulates 5-HT4. Right. So metoclopramide at high doses. What is the effect of? आदित्य गुप्ता, तुक्के लगते हैं, तुक्के लगने के लिए तुक्के मारना भी जरूरी है। और देखो, तुक्का मारना भी अपने आप में एक साइंस है, आर्ट है, राइट। और जब भी हम ग्रैंड टेस्ट देते हैं, एमसीक्यू का प्रैक्टिस करते हैं, तो तुक्का मारना सीखते हैं उसमें, ठीक है, राइट। सो व्हाट इज द आंसर हियर, गाइस? Metoclopramide at high doses blocks D2 and 5-HT3, blocks D2, 5-HT3 and 5-HT4, blocks D2 and 5-HT3, stimulates 5-HT4. Stimulates 5-HT4. So what is the answer? Excellent, guys. Here, D is the right answer. Remember, at normal doses, metoclopramide just blocks D2, but at high doses, at normal doses, it blocks D2. At high doses, it not only blocks 5-HT3 but also stimulates 5-HT4. That is the reason why. Metoclopramide is a much more effective anti-emetic and prokinetic as compared to domperidone. It is a more serious drug. That is why I use it in chemotherapy-induced nausea vomiting. I can use metoclopramide but not domperidone, right? That brings us to the last MCQ for today, guys, right? See, Mohan Raj, location of 5-HT3 and 4, there is nothing to revise. 5-HT3 is located in the CTZ area. It gives us antiemetic effect. 5-HT4 is located in your intestine. That increases contraction of your GIT or motility, right? So EPS, yeah, I'm not going into EPS. Which of the following is mu receptor agonist used in diarrhea? So this is an MCQ based upon a new drug, right? Which of the following is a mu receptor agonist used in diarrhea? Which is a mu receptor agonist used in diarrhea? So one mu receptor agonist, all of you know, that is used in diarrhea is called as loperamide, right? One is loperamide. We know about loperamide. There is another one which can be used in diarrhea, mu receptor agonist that can be used in diarrhea. It is excellent, guys, excellent. Most of you have given the answer, right? The answer is alloxadolin. See, alloxadolin, it's a mu agonist and kappa antagonist that can be used for treatment of diarrhea. Alloxadolin is a mu agonist and kappa antagonist used in diarrhea. And most of you have given the answer right, guys. I'm very proud of you. So, guys, this is all for today's session. This is your next week, and this is the last week. This is the last week. Now you can see, you can look back at the first week when I started this, and we have already reached to the last week. And week by week, we have been covering gradually, one by one, each and every topic we have been covering, right? And that is the beauty of weekly pharmacology, by which we can, grasp the subject more. So after covering this, you'll realize what is the beauty of weekly pharma when you go towards the end of your exam, and you'll see that you will be much better off than your peers, right, guys? So you can take a screenshot of this. I'll post this on Instagram as well. And again, amazing. It was an amazing live session. I'm sorry for the initial hiccups we had with today's session, but anyways, you guys participated with much enthusiasm and it was amazing. You guys rocked for me, and irrespective of how you've given the answer, most of you participated enthusiastically, and I'm really proud of all of you guys. So guys, all the best, guys. All the best to all of you guys. And again, happy festivities to all of you. Happy Dashera to all of you. Right, you can enjoy one day. You can take one day off. You are allowed to do that. We are humans. We are not computers. We are not robots. So if you are thinking that taking one day off will jeopardize your preparation, don't think like that. Right, taking one day off might be more productive. You might come back stronger after that, because we humans, we need some kind of break in between as well. So if you're thinking of taking one day break in Dashera, you can go ahead, you can take that break. If not for the whole day, at least take break for 4 to 6 hours. You can do that. You can do that. Mudit Gar, Harris cell leukemia, yeah, I actually told it wrong. What you learned in pathology is correct. See, I'm not a pathologist. I don't know much about pathology, right? All right, guys. So good night to all of you guys, and lots of love and blessings to all of you. Take care. My blessings are always with you. Take care, guys.